A chroeso cynnes iawn I bob un ohonoch chi. Dwi am gychwyn heddiw efo ymddiheuriad diffiant am y ffaith bod ni yn cychwyn y cyfarfod yma yn hwyrach nag o'n i'n disgwyl. A very good morning to each and every one of you to today's board meeting, and I certainly want to extend a sincere apology to everyone for the fact that we're starting this meeting later than we had scheduled. Dydy technoleg ddim wedi bod yn ffrind I ni y bore yma. Technology has not been our friend this morning, and we experienced some difficulties when we started our meeting initially, which meant that members of the public couldn't access the meeting. And of course, it is very, very important that we hold our meetings in public, and the fact that the public couldn't access the meeting was a significant problem that we needed to address and to resolve. We think we have now resolved that, but I am just going to pause just for a second or two and invite Adrian, our Director of Comms and Engagement, just to give us the assurance that public access is now working properly and effectively for this meeting. Adrian.
Thank you very much, Chair. Again, please accept our sincere apologies for the technical issues that were faced at the start of this meeting. We have reissued a new web link for today's meeting. We have tested that with a number of external partners and external colleagues who are all telling me that that link is now working for them. So that does give me assurance that the meeting is good to start. And also, in addition to that, clearly a recording of this meeting will be available from our channels immediately after the conclusion of today's board meeting. Thank you.
Thank you, Adrian, and thank you to you and all of your colleagues for addressing those issues and resolving things so smoothly and so effectively. Much appreciated. Felly, croeso I bob un ohonoch chi un cyfarfod. Fel y gwelwch chi, dyn ni'n cynnal y cyfarfod heddiw yn rhithwyr, a mae'n cael ei ffrydio yn fyw ar ein gwefan, ac fel mae Adrian eisoes wedi deud, bydd na recordiad o'r cyfarfod ar gael ar ôl heddiw ar ein gwefan ac ar ein platformau cymdeithasol. So a very good morning to everyone. This is an extraordinary meeting of our board. We're holding it virtually and it is being live streamed on our website. And as Adrian has just explained, a recording of the meeting will be available to view after today's event. Os ga I gyflwyno yn hunan I gychwyn, Carl Cooper ydw I, sef cadeirydd Bwrdd Iechyd a Ddysgu Powys. Dyn ni fel bwrdd yn gorff llywodraethol ar gyfer y sefydliad, ac dyn ni'n cynnwys aelodau annibynnol ac aelodau gweithredol, a chyda'n gilydd ni sydd yn ffurfio bwrdd unedol, ac mae gennym ni ambell I gyfrifoldeb pwysig. 4 ohonyn nhw yn bennaf, sef yn gyntaf pennu cyfeiriad strategol ar gyfer y sefydliad. Yn ail, pennu'r archwaith risg wrth gyflawni ein hamcanion strategol. Yn drydydd, monitro cyflawniad a pherfformiad yn erbyn ein hamcanion strategol. Ac yn olaf, ond yn sicr nid y lleiaf, gosod, modelu a lliwio naws a diwylliant ein sefydliad. I want to just introduce myself initially. My name is Carl Cooper and I am the chair of Powys Teaching Health Board. We as a board are the governing body of our organisation, and we are made up of independent members and of executive members, and together we form a unitary board. We have essentially 4 main responsibilities. We are here to set the strategic direction for the organisation. We're also here to set the risk appetite in the delivery of our strategic aims. Thirdly, we're here to monitor delivery and performance against those strategic aims. And fourthly, but absolutely not least, we are here to set, to model and to shape the tone and culture of our organisation, ensuring that how we do things is as important, perhaps even more important, than what we do. Now, as a board, we routinely meet bi-monthly, but today we have convened this extraordinary meeting because we need to consider important and urgent matters. The agenda that's published on our website indicates that we will initially consider the Charitable Fund's annual report and accounts. However, on further consideration, I've decided to postpone that particular agenda item to our scheduled board meeting on the 29th of January. And that will enable us today to focus on the substantial item on our agenda, i.e. the urgent mitigating actions in relation to the delivery of our annual delivery plan for this financial year. Today, we need to give consideration to some very difficult decisions, and I'll say a little bit more about that when we get to the agenda item itself. Mae'r agenda ar gyfer heddiw ac mae'r papurau yn ôl ein harfer ar gael ar-lein, ac bydd cydweithwyr yn rhannu cyflwyniad gan roi sylw manwl i'r bwrdd i'r camau lliniaru arfaethedig cyn i ni fel bwrdd wneud penderfyniad. Ac fe welwch chi ar y sgrin yn y man enwau y bobl sydd yn cymryd rhan yn y cyfarfod heddiw, sef aelodau'r bwrdd, a'r mynychwyr ychwanegol sydd yn bresennol yn ein cyfarfod heddiw. Ynghyd â'r cydweithwyr sydd yn methu bod gyda ni heddiw ac dyn ni wedi derbyn eu ymddiheuriadau am absenoldeb. And so today's papers, the agenda and the papers, are all available online from our website. In a few moments, colleagues will share a presentation that will take us as a board in some detail through the proposed mitigating actions before we take any decisions today. And just in a few moments on the screen, you will see details of the names of those attending our meeting today, any additional attendees, and also those colleagues who can't be with us today and whose apologies for absence we have accepted. As a board, in line with NHS requirements, we meet in public, but it's important perhaps to draw the distinction in the fact that we meet in public, but this isn't a public meeting. So we don't have any direct contributions from members of the public during our meeting. However, we always have, as a standing item on our agenda, questions from the public, and if members of the public would like to submit a question for any of our board meetings, then information as to how to do that can be found on our website. I'm delighted today to be able to welcome Ian Thomas. Ian is a brand new member of our board, an independent member. This is his first board meeting, and Ian, it's really good to have you with us. We certainly look forward to your contribution and to working with you over the coming months and years. We're also joined by colleagues from Audit Wales, and certainly everybody is very, very welcome. If you notice that during the meeting, I and others temporarily look away from our cameras, then just to give you an assurance, that's simply because we're working off multiple screens and we may be reading papers or accessing information to our left or to our right in order to be able to participate effectively in the meeting. And so we now, without any further ado, move to the agenda, published, as I said, on our website with the papers. And we turn initially to item 1.2 of our agenda, declarations of interest. Now, as board members, the register of interests contain all of our declared interests, and that is available publicly from our website. However, for today's meeting, and specifically the item on the additional mitigating actions and our annual delivery plan, we recognise that for some of our board members, this may have quite a close impact. We all work in Powys, and some of us live in Powys, or indeed have close relatives that live in Powys, and therefore may be in receipt of healthcare services from the Health Board and impacted by whatever decisions we ultimately make today. We recognise that, we acknowledge that, and I want to remind each and every one of us that we are here to act in the best interest of our health board and of the population we serve. A very important principle to bear in mind and to adhere to as we go through our discussions and meeting today. And so we move to the substantial agenda item. And just by way of introduction to this item, I just want to remind us that at the start of the year, as a board, we approved our Health Board's annual delivery plan, a very important document setting out what we intended to deliver for the population of Powys during 2024-25. Now, that plan also sets out the associated costs to delivering that plan, which at the time was a deficit budget of £24.9 million. Following discussion with Welsh Government at the time, we actually improved that financial position in May 2004 to a forecast deficit of £22.9 million. And that was against a control total of £12 million. Now, as a board, we fully recognise the requirement to have a break-even budget that has no deficit associated with it, as per our statutory responsibilities. Regrettably, it hasn't been possible to achieve this year, nor in fact to achieve our control total of £12 million set for us by Welsh Government. I think it's important to note at this juncture that the annual plan that we approved contained a 9.9 million savings commitment for the organisation. And actually, we are on track to deliver those savings. Bearing in mind also that last year we delivered a savings target of 7.5 million. Now, these are the largest savings proportionately that this health board has ever made, certainly in current memory. And on behalf of the board, I just want to express gratitude to everyone across the organisation whose efforts have delivered and continue to deliver these savings and efficiencies. Thank you very much. Throughout our year, the board has been very carefully monitoring both our finance and performance position against our forecast deficit budget of 22.9 million, always ensuring that our responsibilities to our patients and our population are at the heart of our thinking and decision making. But today we have to consider options that we have previously discounted to ensure we balance our overall financial responsibilities. And Hayley, our Chief Executive Officer, and other executive colleagues, just in a few moments, will take us through a presentation summarising the paper that has been provided to us as a board and that is available, as I've said a few times, publicly via our website. Now, to support that paper and the discussions today, a draft integrated impact assessment has been produced and it has been made available to the board. We will need to seriously consider today the extent to which the draft assessment offers sufficient assurance in relation to the consequences of any decisions that are being considered. I want to also explain that I have spoken directly with the Cabinet Secretary for Health and Social Care. We recognise, and actually we are very, very grateful for the additional funding that we, along with other health boards, received in December. This has reduced the deficit, the forecast deficit of 22.9 million to 15.8 million. But it hasn't alleviated our in-year financial pressures, and this will be fully explained within the presentation. Welsh Government has been consistently clear with us that we must meet the requirements placed upon us as regards finances and as regards the provision of safe, high quality, timely healthcare for the people of Powys. Now, notwithstanding the difficult and complex content of our meeting today, I take this opportunity to assure everyone that as a board, we take very seriously our responsibilities to the communities of Powys and the people we serve. Our job as a board is to ensure we thoroughly consider the proposals together with the associated risks, the impacts on patients, on GP practices, and on other stakeholders. And we will seek to navigate a balanced approach to fulfilling our requirements, legal, statutory, quality, equality requirements that are placed upon us. So that with those few observations of introduction, I'm now going to hand over to Hayley, our Chief Executive Officer, who will begin presenting the information to us. Thank you, Hayley.
Diolch, Cadeirydd, a bore da pawb. Thank you, and good morning, everybody. Thank you for that introduction, Carl. It was a really important introduction that set out very clearly the Welsh Government expectations for the Health Board this financial year, and those have been consistently set for us, both in relation to ensuring that as a board we deliver against the board approved plan, and it is really important that we bear that in mind and those points you've just raised whilst we consider the discussions today. So we have prepared a presentation to summarise to you the key drivers of the Health Board's deficit position, some of the actions that we have already taken this year to deliver, and also we'll be setting out very clearly the proposals for the board's consideration for further urgent action to mitigate the financial gap we're facing by year end. And as Carl has just mentioned, we will be considering the draft impact assessment and the particular risks we are facing in relation to delivery. So again, I wanted to, I'm aware that the slides will be coming up soon, so I'm wondering if people are sharing the slides. I'm not able to see that at the moment. Are people able to put up the slides, if that's okay? Great, thank you, thanks very much. So as the Chair has set out, we approved a plan earlier this year to end with a deficit of 22.9 million. And the level of savings we would have to achieve is 9.9 million, which is, as the Chair pointed out, a greater level of savings than the Health Board has previously made in a single year. And I'm really, again, reiterate the Chair's thanks for the relentless focus of our hard-working staff, who are continuously focused on providing the best and most cost-effective care for our population. And I'm pleased we are making good progress against those saving plans. So we'll be covering that detail a little bit later. We have had extra pressures on our budget above our plan in relation to costs associated with both the demand and the number and the cost of continuing healthcare cases, as well as in relation to our ongoing reliance on agency and locum workforce to sustain services in the county. In relation to commissioning costs, the levels of growth and activity have exceeded the levels of activity we had planned for. And there are two issues to highlight here, and we'll cover a little bit later, which is that this is in part caused by substantial pathways of care delays and increased lengths of stay. And this is manifesting in increased costs across both the community and the acute sector. So it's clear that without taking further actions as a health board, we could end up at the year end 9.4 million worse than we had planned. So before the financial year ends in March, it is important as accountable officer for the organisation that I set out very clearly to the board the additional actions we need to take to deliver our financial plan. So therefore, during this presentation, we will be presenting to you options to consider about how we best make those further savings. We also mentioned earlier around the additional allocation that we have received from Welsh Government of 7.1 million in month 8, which, as the Chair has mentioned, we really welcome and in part has recognised the additional cost of the commissioning position. This additional Welsh Government funding resulted in an updated year-end forecast of 15.8 million. As you're also aware, as a health board, we were placed into a higher level of escalation at level 4 for finance, strategy and planning under the NHS Wales Oversight and Escalation Framework. And clearly, it is our job to make sure that as a board, we work hard to try and exit this level of escalation for this domain in a managed way, but also maintaining our focus on keeping routine level status across all the other 5 domains that we are assessed against. So we have had our first formal escalation meeting with Welsh Government, and we discussed in this meeting the importance of working on commissioning as a key priority and the posed risk to financial recovery that our commissioning pressure is causing. As part of the escalation discussions, Welsh Government are working with us to provide additional scrutiny and advice, and that is particularly in light of the complexity of our commissioning arrangements and the elements of commissioning services across the border in England. Next slide, please, Liz. So the further action we'll be covering during this presentation are related to 3 key areas. So firstly, the introduction of a recruitment freeze and the reduction of agency and locum spending. And finally, we're also putting forward for the board's consideration details about revising routine elective activity with NHS providers in England. And we'll cover that detail in a while. Next slide, please. This infographic has been developed and we have had really positive feedback that this is helping people to understand how we as a health board are spending our £440 million budget and how we allocate our resources. So the infographic explains that on the basis of every £100 that we spend, around 1/3 is spent on the services directly provided by the health board and on our staff. This includes our hard-working frontline staff and also the essential teams of support staff. Nearly 1/5 is spent on primary care, so that comprises both GPs and family doctors, our NHS dentistry, pharmacy, optometry, as well as prescribing drugs and appliances. We spend around half on paying then for services that are provided for the Powys residents, but by other organisations. And this includes hospital services in England and Wales, ambulance services, specialised services, the continuing healthcare and free funded nursing care, and also the support that we commission and the third sector provides. So because the NHS faces a wide range of pressures and demands, the financial plan that we agreed earlier this year effectively means that because we're in a deficit position, for every £100 that we spend, we are overspending by £5. So I really hope that this has helped us put a little bit of broader context and helpful context before we go into more technical detail. And I'll be handing over now to Pete Hopgood, our Director of Finance, to take us through the detail.
Yeah, thank you, Hayley. And thanks for introducing me. Hello, everyone. Pete Hopgood, Director of Finance. So the following slides I'm going to take you through are in the same format as we present our financial position to the board in every meeting. So it will be familiar to the board and to the public watching. I'm going to take us through in a bit more detail in terms of those areas that Carl and Hayley have already identified. In the slides, I will be focusing on our revenue position. So as you heard, we've been monitoring our financial performance against our deficit plan of 22.9 million. Following the allocation of additional funding in month 8, as Hayley and Carl have alluded to, that deficit plan target is now 15.8 million. In relation to that 15.8 million, our plan would have been to have been at a position at month 8 of £0.5 million overspend. Our actual position is an overspend of 16.2 million, giving us an adverse variance against our own plan of 5.7 million. As we've already touched on, the key drivers for that variance and the key pressure areas for us are in relation to commissioning, our spend on agency, and our spend on complex care, continuing healthcare. Now, those pressures are being offset by some good performance in other areas, and we'll go on to that in the next few slides. So if we could move forward, please. This next slide is giving a summary of our overall position against our key expenditure drive areas. So the first column is the area of spend. The next column is our plan budget year to date. Then the next column is our actual year to date, giving you then our operational variance against our deficit plan. And just a reminder, this is our operational variance against our deficit plan with the additional funding of 15.8 million. If you look on that column, and for those the public watching, the red figures are the ones where we're underspending against the plan, and the black figures are where we're overspending against the plan. And as you can see, the key overspend areas relate to our pay position, and that's linked to our spend on agency, which I'll come on to in future slides. Our healthcare services from other bodies position with an overspend of 5.2 million. And our continuing healthcare and funded nursing care position, which has a 2 million variance. And you can see that it links back to Hayley's slide earlier, that the budget year to date gives you an indication of where we spend the majority of our money, with our healthcare services from other bodies at 117, 118 million year to date being the key area in terms of budget, and actual spend of 123 million. If we can move forward, please. This next slide again takes us to another level of detail. This is detailing again at a summary level our key spend areas against our provider arm. These are the services that we provide within Powys. If you look at the top box column there, you can see that our pay position has that £1.9 million overspend to date. And then we look at that across our service areas. Our main area of pressure in that regard is in relation to our mental health and learning disabilities directorate area. And again, this is where the main pressure in relation to use of agency based on the number of vacancies and the acuity of our patients is seen. If again, we can move forward, please. This next slide details our variable pay spend. So includes our agency spend, which in the main is the blue area of the chart, and our spend on other areas such as bank and overtime, etc., and locums in terms of continuing to provide our services. It's worth highlighting that we have seen an improvement in this area in recent months, particularly in the community services group area, but continued to see pressure in relation to agency and our locum use in our mental health services. It's worth noting that this is significant for us. Our pay position is £1.9 million overspent for the year to date. Our total spend on agency is 9.9% of our total pay spend, and that is against an average for Wales of 2.9%. So we're a significant outlier in terms of our use of agency. As referenced earlier, we know that in the main, the reasons for that is to cover our vacancies, to maintain our safe and appropriate level of care for our patients, and in relation to the acuity of those patients that we're now caring for. Worth noting as well that we have a variable pay group which is focused on this area. This has been an area of pressure ongoing over recent months and years. It's an area of focus where action is taken to minimise that spend as far as possible. If we can move forward, please. And the next area in terms of those services we commission from other bodies, included in the slide is that a small summary table which details our plan to date, our actual to date, and that variance, as I highlighted, of 5.2 million. As you can see, the main pressure areas in relation to our English providers, where they're significantly good levels of performance have meant that they've treated more patients and cared for more patients than we originally were planning for and anticipating, and that extra performance and extra activity is given that cost pressure year to date of 4 million. There are pressures in other areas, including with our Welsh providers, where we have seen an increase in terms of emergency activity, and in the main, that cost has been from the provision that Cwmtaf Morgannwg Health Board provide in that area. And similarly, in relation to the Joint Commissioning Committee, which represents all health bodies, there's a pressure against that position to date of just over £500,000 at 528,000. Excuse me. If we can move on, please. This next area, again, one that Hayley highlighted, we know that there's a significant pressure within our system. This is a pressure for ourselves and also our local authority partners in terms of those delays. As mentioned, there are delays in relation to health and in relation to social care capacity. We track this area because it's a significant cost for us. It's also an area of significant opportunity to improve our action and our efficiency in this area, which would help to improve our overall financial position. If we can move forward, please. The next area is one that has a very positive impact on our financial position. This is prescribing. The medicine management team have delivered a significant contribution towards our overall savings target. They originally had a target to deliver £1.1 million worth of savings in the year. They currently forecast to deliver just under 1.8 million and delivering an underspend position. So this is a significant contribution to offset some of those pressures that I've already highlighted earlier in the report. If we can move forward, please. The next area, continuing healthcare and complex care. This has been a significant area of pressure for us. As you can see from the table included, this is an area where we've seen significant increases in our costs. That has been in relation to the number of packages of care that are being provided and the higher levels of acuity of those packages that are being provided. So that has seen an increase in terms of the number and the cost. Again, this is an area of focus in terms of ensuring that all action being taken as far as possible to make sure that those controls are in place to minimise those costs as far as possible, while providing the right packages of care for those individuals who are eligible for that. And it's worth noting that a reference to pressure on the system that we face in terms of our delays, our discharge delays, well, those pressures, those delays have and then an impact in terms of our continuing healthcare, because our patients then deteriorate in terms of being in the hospital longer than they need to, and also in terms of our commission services costs, because people delayed in beds end up being an additional cost to the health board. If we could move forward, please. And as again, Carl and Hayley have described, we set ourselves a savings target within our deficit plan of 9.9 million. This again summarizes our financial performance in terms of delivering those savings. It's categorized against the key headings as included on the table. And currently our forecast delivery against that 9.9 million target is just short of that at 9.86 million. It is worth noting that of that delivery, the recurrent element of that is 7.2 million. And clearly it's important that we deliver our savings target on a recurrent basis to stop it then being an additional pressure moving into the next financial year. It is worth noting that our performance against those targets has been varied. In the column that has forecast v target, those areas which are highlighted, which are in black, they are the areas where we're overperforming against the target. Those in red is where there's a shortfall. You can see that the areas which are overperforming are offsetting those areas where we haven't delivered at the target as set. So for example, in relation to our medicines management that I referenced earlier, a target of 1.1 million, delivery of 1.7 million, meaning that there's an excess delivery above target of 635,000. If we can move on, please. This next slide, we regularly monitor our risks and our opportunities against our position. As you appreciate, as a complex health board with lots of moving parts, pressures and demands across our system, that there are always risks and opportunities. The key one I just wanted to flag on there is that, as we've referenced, assessed total potential full year pressure against our plan of 9.4 million. And that is the significant risk in terms of needing to mitigate to deliver the deficit plan target of 15.8 million. If we can move on, please. So I very quickly go through this next slide. It's just a summary of the situation that Carl outlined right at the beginning. So our original health board plan was set at a 25 million deficit position. We improved that deficit position by 2 million to 23 million based on ongoing discussions and dialogue. Following the allocation of the additional funding as identified of 7.2 million, our revised financial plan target is 15.8 million. Funding very welcome and well received, but the funding being received and a reduction in our target means that we still have that pressure and variance against our financial plan. And as at month 8, that is assessed and forecast to be in the order of 9.4 million. And that's where we need to move into those areas of identification for mitigating actions to take to reduce that financial variance. As also referencing that as we move forward this, we do monitor our underlying deficit position. Obviously, that's important and significant as we move into the next financial year. The importance of that is around us delivering recurrent improvement year on year. If it's non-recurrent, it remains an ask for our next financial year. Our current assessed underlying deficit going into next year is 26.9 million. Next slide, please. I think, again, this slide is adding a bit more detail to what I've already said, but just to summarise, as at month 8, we're reporting a £16.26 million deficit position. That compares to our deficit plan against the 15.8 million target, a revised profile of 10.5 million, giving us an adverse variance of 5.746 million. As of detailed, we're on track to deliver on £9.9 million savings target, but it is important that we achieve that on a recurrent basis. And the key areas of pressure are in relation to our commissioning of healthcare from other bodies, which is overperforming, creating an overspend, both in emergency and elective activity. Key operational pressures are highlighted in relation to discharging patients from hospitals and the related increased costs in relation to agency, and especially in the mental health services. Again, as reported, our CHC costs are much higher than we planned for, and again, due to the increase in number of packages and the acuity and the level of care required in those packages. I think that covers the key things on that slide. So again, as we move forward, thank you. So as already been introduced, the key areas of opportunity, where there is potential to reduce our current expenditure, have been identified as a vacancy freeze, where we add some more detail in later slides, where there are a number of posts within a vacancy process that could be frozen with a potential savings delivery of 0.4 million. We spend on average £1 million per month on agency and locums, giving us an opportunity to reduce spend of up to 3 million. And as referenced, that significant good performance in terms of rings providers and that additional activity, an opportunity to look at that level of activity profile to the end of the year, to look at reducing costs by an estimate of up to 5.7 million. If we move forward, please. So this table is really just to summarise that, and you've got the key areas of potential remedial action, the vacancy freeze, the use of agency, and also there are a number of other smaller actions across all areas which are just summarised up into that position. And then the areas for the subject to the board discussion today around our level of elective activity for the remaining months of this financial year. Against those key areas, there's a maximum amount of expenditure under consideration or a maximum saving opportunity. This is the financial calculation subject to the other considerations around impact that we will discuss further after I finish this section. So there's an opportunity of up to 0.4 million in relation to vacancy freeze, an opportunity of up to 3 million in relation to our agency and locum use, and an opportunity between £500,000 and £1 million across those other areas I referenced. And then depending on the discussion and potential outcome, a range of up to 5.7 million in relation to our elective activity going forward. And if you add up the 0.4, the 3, the 1 and the 5.7, that gives you an area of opportunity, the maximum opportunity of up to 10 million. Excuse me. As we move across, the current sort of percentage delivery against those figures based on current actions are as detailed just at the 0.4 million as per that table. That's as per current actions. There will be continued action in those areas to increase that number, and that will be closely monitored going forward. And then clearly the final point will be subject to our discussion now going forward. And I think that was the last slide for me, and I believe I'm handing over to Deb.
Bore Pawb, Deborah Wood-Lawson, Director of People and Culture. Before I cover the detail in the next two slides, it's important for me to stress how much we value our staff and the significant contribution they make every day to our patients, our population, and to each other. We will continue to invest in their development and opportunities and ensuring that as far as possible they have a positive experience whilst at work and that their well-being is supported. We want our loyal, skilled and committed team to continue to grow with us, train with us and be retained by us. Given the content of the board paper today and the board discussion, we're very conscious that the strength and arrangement set out around vacancies and agency may cause some staff to worry about the impact of these changes on them personally, and we know some might worry that there is a risk of redundancy. Therefore, can I reiterate the message given to the organisation earlier in the week by Hayley as part of her staff briefing? The position of the Health Board is that this is not a call for redundancies, and therefore staff should not unduly worry about this possibility. However, given our challenges and according to the priorities, there will be occasions where we may require some staff to undertake different tasks or work in different ways. In such circumstances, we will be guided by the organisational change policy, and working with staff side representatives, we will support staff should this be the situation. To strengthen our grip and control, as Peter's described, we've now introduced more senior level stroke executive director sign off for all Health Board vacancies, fixed term posts, whether they are new or an extension to an existing post, and the booking of agency staff. We know that some of our staff are concerned about the risk that they may be personally carrying in making these type of staffing decisions, whether that be a decision not to recruit or not to book agency cover. And therefore, we hope that our staff will feel more supported, that these decisions will be taken at a more senior level. So just to build on what Peter said, in terms of the actions already in place around vacancy freeze, in the last 2 weeks, and against the criteria on the slide, we have reviewed the 122 vacancies that were on track at that point. As a result of this review, 40 of these posts have either been frozen or slowed down. We will continue with this director level sign-off process for all future vacancies, which is further overseen by myself and Pete as the Director of Finance, to ensure fairness and consistency of those decisions across all health board teams. Next slide, please. Move on to the next. Thank you. In terms of agency reduction, again, a senior level enhanced scrutiny process will be implemented for all agency bookings to include locum cover. A new risk assessment for agency requests will be implemented next week, which will see all requests requiring the approval of either senior nursing, operational, or medical staff. This process will both apply in and out of hours and will consider the evidence as per the slide to determine whether a booking can be made. We know the significant contribution towards patient care and agency reduction provided by our previous cohorts of internationally educated nurses. Just to reassure, we have a further 6 internationally educated nurses arriving next month, followed by 6 registered mental health nurses to join our mental health teams, and they're due to arrive before the end of this financial year. Also to mention 2 overseas psychiatry doctors, one who has started in mental health and the other will join us next month. Therefore, our increase in overseas colleagues for 24-25 compared to 23-24 is an additional 21 overseas colleagues, and that together makes a significant reduction and contributes to our reducing our reliance on agency and locum cover. Just on agency cover, we'll further enhance our review of roster efficiency and scrutiny, and I know that Claire Roach, as the Executive Director of Nursing, has already met with senior nurses to consider how we do things differently. And Elaine Norton, as the Director of Primary Care, Community Services and Mental Health, has established an operational implementation group. Areas with high consistent staff and availability will need to develop recovery plans to minimise their reliance on agency staff, which will include new ways of working, redeployment of other staff, or possible role changes. All of those strengthened sign-off arrangements and scrutiny that I've just described will be communicated to recruiting managers and the organisation more broadly next week. Thank you. I think I'm handing over to you, Nicola.
Thanks, Deb. My name is Nicola Johnson. I'm the Director of Planning, Performance and Commissioning for the Health Board. This further action that is discussed in the paper is based on one of the drivers that Pete has outlined earlier in the presentation. The rate of elective activity in our NHS England providers is not the only driver of our commissioning overspend, and there are others, but we have focused on this as one of the influenceable areas that we could take action on in Q4, given again the explanation that Pete and others have given in terms of our financial situation. The 3 main providers for Powys residents in England are Robert Jones and Agnes Hunt Orthopaedic Hospital, the Shrewsbury and Telford Hospitals NHS Trust, and the Wye Valley NHS Trust. And they are valued strategic partners for us as our population access both emergency and elective care from them, and they also provide in-reach services for us in terms of particularly planned care provision that's also provided within our sites in Powys. As we've discussed, our year-to-date performance shows a projected overspend, and that is shown for these 3 providers on the slide. If members are wondering why there is a greyed out area under Shrewsbury and Telford, that is due to data flow issues from that trust, which have been openly reported in our performance reports. One of the drivers of the accelerating elective activity over and above what was planned in year in our providers in England is that the waiting times targets in the 2 systems, but in NHS England and NHS Wales, are different. Healthcare is a devolved issue in the UK, and it's entirely legitimate for devolved governments to make different decisions. The waiting times targets are outlined on the slide, currently being 65 weeks for inpatients in NHS England, 104 weeks for inpatients in NHS Wales, and a separate target for outpatients at 52 weeks. As shown in the table below and also in the paper, both Shrewsbury and Telford and Wye Valley are meeting the NHS Wales waiting times targets for our patients, with the maximum reported wait you can see there on the slide. However, there is a small cohort of patients exceeding the Welsh targets in Robert Jones and Agnes Hunt, which again we are well aware of and has been previously reported through the board through the performance reports. As they are NHS England providers and monitored within that system, they are all working towards the NHS England targets. Can I have the next slide, please? To examine the influenceable action that could be taken in Q4, a desktop exercise has been undertaken and 2 scenarios have been considered and modelled based on normal operational planning practice, which is that patients would usually be booked around 6 weeks in advance, and usual scenarios in terms of waiting list management. And those scenarios are outlined on the slide. Members should note that scenario 2 includes scenario 1. They're not mutually exclusive. And the table that's in this presentation and in the paper provides the further detail on the potential impact of the scenarios, both in terms of the numbers of patients that could be affected and the associated expenditure. It should be noted that this is subject to negotiation with providers, and so these projections are heavily caveated at this stage, and there will be a further discussion on the delivery confidence later in the presentation. The modelling is based on routine elective activity. When patients are referred into all secondary care providers, they are assessed and triaged. The referrals assessed and triaged. And so this is based on the modelling of routine elective activity and would exclude cancer patients, those patients assessed as urgent, and due to, again, the discussion under the equality impact section, we will ask providers to exclude under 18-year-olds due to the development and educational impacts which are known on children of actions such as this. It is noted that if the further action was to be agreed, the majority of Powys residents would still not breach NHS waiting times targets, and that's what we would be working with our NHS England providers to achieve. I think I'm passing on the slide pack to, I think it's Claire.
Diolch Nicola, bore da. Good morning everybody. My name's Claire Roach. I'm the Director of Nursing Quality, Women and Family Health. So I just want to take you through some work that we have been doing in relation to assessing the impact of this decision. So a draft integrated impact assessment has been undertaken by myself, the Executive Director of Nursing and Quality, the Director of Therapies, Claire Madsen, the Medical Director, Kate Wright, and our Director of Public Health, Mez Bowley. In addition, our Director of People and Culture, Deb Wood-Lawson, has ensured that the assessment has been cognizant of equality and diversity. It is really important to note that whilst I am the director responsible for quality, as an executive team, we share collective responsibility for the duty of quality. Our impact assessment has specifically addressed the impact on the affected cohort of patients, and it is very important that the board are aware of this. The impact assessment is therefore an isolated impact assessment. It is not a whole system or a whole population assessment. The draft impact assessment is based on the worst case scenario and the full impact of the delayed elective activity. It has been shared with board members to support discussions. And if approved, and once formal discussions have taken place with providers, the impact assessment would be further strengthened and finalised. I would like to draw attention to the middle part of this slide and to explain that the quality impact assessment has been undertaken in line with the 6 domains of quality, which are safe, timely, effective, equitable, efficient, and person-centred. And in all of these domains, our assessments scored highly. So for this cohort of patients, from a safe perspective, we cannot rule out avoidable harm. The provision of care would not be timely and the delay would be impacted. A delay in a pathway of care may be counter to evidence-based pathways, and the delay would apply without regard for individual circumstances, notwithstanding what Nicola just described in terms of our decision around under 18s and urgent pathways of care. The delay is likely to increase administration burden and potentially create additional demand in the system. And from a person-centred perspective, delay in access to planned care does not meet individual patient needs, and patient experience would likely be adversely affected. So to summarise, I would like to hand over to our Medical Director, Kate Wright. Thank you.
Good morning, everybody. So in summary, we do have complex statutory duties, for example, the Financial Duty, the Quality Act and the Socio-Economic Act. The proposal does support financial management within the year and provides a potential to achieve this with a single initiative. However, it is complicated. As Claire has highlighted, it increases waiting times for a significant number of patients, accepting that we have different waiting times across Powys. The potential for further consequences needs careful consideration, and as the draft quality impact assessment demonstrates, this is not a quality-led decision for the patients impacted. I'll now hand over to Mez, who's our Director of Public Health. Thank you.
Diolch, Kate. Bore da, Mez Bowley, Director of Public Health. So there is limited equality data available within the waiting list information. Therefore, the draft assessment has been made and potential adverse equality impacts have been identified, as some are described in the slide presented. So whilst the scenarios proposed do not include those on scheduled care lists, excludes children and young people, and excludes patients on cancer pathways, we cannot mitigate for all equality impacts. And based on board discussion today, it is important that the final integrated impact assessment is completed based on the actual level of deliverability in discussion with NHS England providers. So I'm going to hand over to Hayley now. Diolch, thank you.
Thank you, colleagues, for taking us through that detail. So clearly, there are a number of risks, quality and equality impacts that have been identified through the draft assessment that's been undertaken. And it is clear for us as a board that to support our decision-making process, it is important that we acknowledge that that work will need to be further completed and that our decision is a balance of risks across a number of factors. I also appreciate that it is unusual to present a paper to the board with a low delivery confidence, but until we formally discuss and assess with our English partners the potential level of opportunity that we can deliver to with regards to revising elective activity, we cannot fully complete a delivery confidence assessment or be fully aware of all the potential difficulties and risks associated with implementing this action. So, summarising the presentation, I'm advising the board that we need to have those discussions with our NHS England providers to assess deliverability and risks, and also in order to meet our duty to assess and consider the equality and quality impacts, we also need to finalise our integrated impact assessment to inform the board's final decision. In conclusion, looking further ahead beyond the last quarter of this financial year, we know that the financial position will be challenging, and the exceptional actions set out in this briefing over the last 3 months of this financial year will need to further build and look at this going into our annual plan for 25-26. The reality we face as a board is that we have a significant and substantial underlying financial deficit which we need to address, and we will need to continue to look at difficult choices for the board in setting its annual plan for next year. We have in December received the NHS Wales planning framework and resource allocation detail, which we are working through for next year, and we have a very clear expectation that is set for us that we must deliver our target control deficit of 12 million as a milestone, as a minimum, and that detail is being worked through as we go through to the January through to the March board meetings in finalising our annual plan. As I mentioned earlier, very much at the start, we are in level 4 escalation, and we have identified, working alongside Welsh Government, the discussions that we need to have both in year, but also particularly in setting our plan for next year. And I know as a board, we recognise the gravity of the situation, and I really have welcomed the discussion that we've had through our escalation meetings with Welsh Government, that they are considering through their oversight and escalation framework what actions are required to support the Health Board in making further progress. So I just wanted the board to be aware that, subject to the discussion and decisions today, we will be continuing those close discussions through our escalation meetings with Welsh Government. So I'll now hand back to you, Chair. Diolch, Cadeirydd.
Diolch, Hayley. Thank you very much indeed, and a big thank you to you and exec colleagues for the helpful and effective way that complex and detailed information has been presented. Much appreciated. And just before I open it to discussion, just to highlight Hayley's comments at the end and some of the comments that have been shared with us during the presentation, particularly around the work that still needs to be done in terms of impact assessment and conversations with English providers in order that we can have the full picture in as regards these matters. And also Hayley's comments about that some of these matters, yes, we are considering them in relation to this financial year, but of course they are matters that won't go away and will impact upon our planning for next year and for subsequent years. Now, of course, we will be considering that in some detail at our meeting on the 29th of January, that kind of forward look. And so I think the focus for this meeting is in terms of the considerations, the mitigating actions for this financial year. So thank you so much for that. So with that, I'm going to invite people to come in, to join the conversation, to add to the discussion, to pose questions and so on. So colleagues, please indicate if you'd like to contribute. We're going to go, thank you. We're going to go firstly to Katie, who is the Regional Director for Llais, the Citizens' Voice body. And thank you, Katie. I should have invited you to comment proactively, as it were. So I know that you will want to give your perspective on these matters and in response to the information shared. So good to have you with us, and please do that.
Diolch yn fawr, Carl. Just thought it might be useful just to reiterate the role of Llais as an independent statutory body. We're here to actually not only hear people and people's views and communities' views, but also to make sure that they are listened to. And just to reiterate to members that Llais is not part of the decision-making process today. I think it's fair to say, Carl, that I was really disappointed to read the paper, particularly with the reference to the elective activity. And I've been trying to really understand the impact, particularly on individuals and families and carers, and have had many discussions with executives over the last couple of days. Saying that, I obviously recognise the challenges that are facing both the public sector and the NHS in Wales, which are not unique to Powys, and Powys, along with other areas, are having to make some very, very difficult decisions. The paper was released on Tuesday, and we've not really picked up a huge amount of noise or views or comments from the public at the moment. But I think it's really important to say that regardless of that, there are two things that I'd just like to highlight. Firstly, whenever we go out, the issue around waiting times and access to services and access to care is always at the top of the agenda. And so trying to understand the impact on individuals and families of this proposal, we already know that individuals have concerns around the ability to live fulfilled lives, of pain management, of accessing physiotherapy services, the impact on mental health, the impact on family relationships, the impact on being able to work. So we know that waiting for care has a significant impact, not only on that individual themselves, but also on their wider families and carers. The second point I just want to highlight really is that we obviously are aware that there are a significant number of Powys patients, particularly in the north and the east, who've been on pathways that have enabled them to access services far quicker than other parts of England or Wales. And we've always seen that as a really positive experience for individuals being able to receive treatment quickly. I think since I've been in this role, there's always been a significant differential between the north and the northeast and the south Powys. And I suppose it's really sad and very frustrating that this proposal in effect would be about levelling down rather than levelling up, which was always, I think, everybody's aspiration. So turning to the proposal being discussed today, reading it, I just think there's some very disturbing data from a patient perspective. The fact that, particularly in scenario 1, it's likely to impact over 4,000 people, and with scenario 2, it could impact on 10,000 patients. And that patients can wait an extra 5 or 11 weeks on top of the existing waiting times, and the impact that might have on people who are already on waiting lists. I'd like to reference the slides, I think, Mez, particularly your slide around equality. and although appreciating the IIA hasn't, the integrated impact assessment hasn't yet been published, you know, that my concern about some of the information that's contained within that document, particularly relating to the equality impact assessment, particularly relating to the demographics of Powys and the impact it could have on older people, the socioeconomic challenges, the fact that it's quite likely that individuals may consider paying for services privately. You also mentioned disability and carers within that particular slide. So I suppose in summary, our real concern is that this short-term decision has really long-term implications, as you've just highlighted, Carl. And so there's not much more to say other than we are extremely concerned and dismayed, and really concerned about the impact on patients, potentially 10,000 of them, should this proposal be agreed today.
Thank you, Katie. A really important and rather sobering, perhaps, contribution. And you're absolutely right to highlight both the voice of patients and the concerns of the population that ultimately we are here to serve. And as I said in my introduction to this meeting, that's a responsibility that is centre stage for us and that we take very seriously. Thank you. So we have a few people wanting to contribute. I'm going to go firstly to our Executive Director for Primary and Community Care, Elaine Lawton. Thank you, Elaine.
Bore da, good morning everybody. I'm Elaine Lawton, Exec Director of Primary Care Community and Mental Health. What I wanted to contribute at this point is I held a meeting this week with all of our GP practices. We had 17 people attend and the local medical committee also, to share with them the paper considered by the board today, and to hear from them their views and any concerns that they wanted to raise. And I just wanted to share back a few of those key points. I think firstly, I think there was a good understanding of the position that we're in, but obviously concern about the impact on our population should the decision be made to proceed. There was a view that the needs of the population would continue to demand additional time from general practice at a time of real seasonal pressure and challenge in terms of delivery of services, and recognising that although there may not be anything more that can be done within general practice, there may be a demand from patients to seek to expedite appointments or to move providers. But there would also be an ongoing and potentially a growing implication for pain medication or other medications to support people whilst they were waiting. Fundamentally, the single largest issue that they wanted us to consider is how we would communicate with our population and how we would support them during this time period, how we would enable that clear communication to come quickly, and how we would again provide some of the services that we already have in place. So we already have a waiting well service, and that information is accessible on our website. And we have a living well service as well, who can support and people can self-refer through that route. So I just wanted to highlight those concerns that were raised, and recognise the potential impact for our population as well as for our primary care providers, dependent on the outcome of the decision that we make today.
Thank you, Elaine, and I'm really pleased to hear about the engagement with and conversations with GPs and primary care providers, clearly extremely important partners in Powys, and of course, as Katie highlighted, again, an emphasis on being very, very clear about the impact on people, and so thank you. So we go now to Steve Elliott. Steve is our finance lead, our independent member finance lead on our board. And over to you, Steve.
Boridar, good morning. Thanks, Carl. Yes, Steve Elliott's independent member. Obviously, it's a significant concern that we've got to this point financially this year, although obviously recognise that one of the key drivers, as outlined, has been the additional activity that has been coming through at throughout up to this year to date. I mean, before we take these sort of difficult decisions, we'd just like to get some more assurance that every other action has been taken within the organisation to manage budgets, and perhaps if you could say a bit more about the Director of Performance Reviews and Hayley's led finance reviews that are part of the grip and control mechanisms, and to how successful they have been. Sorry, a couple of other questions. I note that in terms of performance, that on one of the tables, that it's actually Wye Valley Trust that seemed to be a more significant overperformer than the other two English providers, and I just wonder why that is the case, and what particular actions could be taken with Wye Valley to try and mitigate that. I wonder if perhaps we could say a bit more about what the implications are if we don't receive the strategic cash funding that we're looking for, and I think that's outlined as in the risks table that's presented. And finally, I just wondered if there's anything more that we can do should we need to take a decision to delay planned care activity in terms of mitigating the impact on patients waiting for treatment, in terms of working with them to be as well as possible while they are waiting for treatment. Diolch, thank you.
Thank you, Steve. Again, key questions. I'm going to ask Pete initially to respond. I mean, essentially, Steve raises four things: one around grip and control, one around Wye Valley, strategic cash, and mitigating impact on patients. But come to you first, Steve, for the Pete, for the financial matters.
Yeah, thank you, Steve. Thank you, Carla. Steve, really important questions. Carl, if you could help me with those 4 bullet points, if I get lost in answering the question, that'd be helpful. I think in terms of the first one around grip and control, there's been a range of actions that the board have implemented, or the exec team and board have implemented. They've been focusing on both our pay and our non-pay position. As I referenced earlier, we have our variable pay and agency scrutiny group, which is really looking at all those actions we can take to reduce that level of spend. And this next level of action, as Deb outlined, is taking that to an even more enhanced level. We know that we had our temporary changes that have been made earlier in this year. That is delivering a level of financial benefit based on the increased efficiency in those areas. So that is an action also been taken. All of our non-pay spend is reviewed, with spend above a certain level having to be reviewed and challenged to make sure all is essential. We continue to look at all of our areas to maximise any reduction in spend to help improve our run rate, and also looking at any potential slippage against areas of funding and opportunity, and that's done on an ongoing basis. We've triggered our admin review to look at areas of efficiency and to reduce our spend. Similar reviews across our estates, work around standardisation of our rosters, other work focusing on our mental health urgent care pathways, our community model, and our work around our MSK first contact practitioner and our community cardiology approach. So there's been a raft of areas and actions. I'll comment on the performance review as well, and then I'm sure Hayley will want to add. But in terms of those reviews, the overall directorate reviews include financial performance with an understanding of the current position, the forecast position, and delivery against savings. But what the board would be aware, because it's been regularly reported and is known outside of the organisation, is that those key cost pressure drivers relate to our commission services position, as we've highlighted and talked about, and we can move on to that part. Our spend on agency in relation to maintaining our capacity to meet demand and the number of vacancies and acuity, and that increased demand in relation to continuing healthcare. So there's a raft of actions, but they come down to the key areas of focus. In relation to our Our position pending this board discussion today and pending any decision made, we will track and monitor the impact of that. We will monitor that against our current forecast and the likely position, and we will keep that full engagement with Welsh Government via our reporting in our monthly monitoring returns and our regular meetings with them in terms of our position, our outturn and the relating cash support as needed. Just to check other points, Carl. I think I've covered two or three there.
I know that I was going to ask Hayley to bring in executive colleagues, or as Hayley you think might be helpful, but indeed you might want to comment yourself as well. But just whilst we're with you, Pete, there was the question about the availability of strategic cash support, or not, as the case may be.
Yeah, so I think I just answered that in my previous comment, that pending our analysis of what any board decisions mean in terms of our position, our likely outturn, that will then trigger those further discussions with Welsh Government as and if needed. Okay,
I will go back to Steve to check, Steve, whether you think that that you've had the assurance that you're seeking. But Hayley, anything from you, or do you want to bring in any of your exec colleagues to address the questions that Steve has posed? You're on mute, Hayley.
Sorry, apologies. Or yeah, in relation to the further arrangements around performance, clearly we've got our regular performance arrangements that we've got in place, where we meet and we look across all of the domains of delivery that a team will deliver. But in addition to that, we now have Chief Exec, myself and Pete as Director of Finance meeting regularly with each director to run through quite forensically where we are in relation of delivery of the financial plan, both around the run rate and the savings delivery, as well as the additional mitigating actions that the team can take to address that. So that has been enhanced during this period, and we continue to follow that. And in terms of the strategic cash support, the request against our original deficit plan to deliver against the 23 million has been already submitted to Welsh Government, and subject to today's decisions, we will be updating Welsh Government on the impact of that, as Pete suggested, and I will be writing to them after that discussion to inform them of the updated position. I know that you also asked about keeping people waiting well, and I just wondered whether Elaine Lawton would like to come in on that point.
Thank you, Hayley. I mentioned it briefly previously when I was talking about GP feedback, but we have an existing Waiting Well team and a Living Well service. There's quite a comprehensive range of information available on our website, on our internet website, which is accessible to all of our public. But we also have a very small team that are able to contact patients by phone and talk through advice and signposting and services for them during that waiting well period. And again, dependent on the outcome of the decision today, we can look at whether there is something we can do to stand up some more of that service for our population.
Thank you, Elaine. I wonder, Nicola Johnson, Executive Director of Commissioning and Performance, particularly in relation to Steve's question on how we are managing, if you like, the more significant overperformance in Wye Valley. I wonder if you might offer a comment.
Thank you. As reported to the board, there's been ongoing growth across all our providers in NHS England over the last 5 years. The table shows the information to this year. There have been operational difficulties in Robert Jones and Agnes Hunt, which has damped down the activity to some extent in year. And obviously there are those data flow issues in Shrewsbury and Telford again, which we've come to an arrangement with them, as they have with all their commissioners. But the underlying direction with all three providers is growth over the last 5 years. It is showing itself for those reasons more significantly in Wye Valley Trust in this year. And again, don't want to give the impression that's because in inverted commas, there's a problem. The commissioning system in NHS England does incentivise productivity and efficiency, and we can see that coming through that system. The main drivers are in the emergency elements, and to some extent in same-day emergency care, but there is that really stark underlying trend in terms of increases in elective activity because of those levers incentivising that productivity and efficiency and those differences in the waiting times target. Obviously, we're in close conversation with them, and we will be working with them on sort of balancing the risks of that increase in activity between the commission and the provider into next year, Steve. But I hope that answers the question to some extent.
Thanks, Nick. Steve, any response from you, or any supplementary question?
Yeah, thank you for the answers. Could I just come back on the strategic cash issue? Because I think, Pete, what you've outlined is that obviously subject to the outcome of the discussion today, there will be further discussions with Welsh Government regarding strategic cash. But in the risk table, you outlined that ultimately we could be in a situation where we don't secure the full level of strategic cash required. So I just wondered if you could just say a little bit more about what does that actually mean in practice, and what actions would have to be taken by the board if that was the case. Thank you.
Okay, so I think, just to clarify, so we submitted our indications to Welsh Government, the level of strategic cash requirement, based on our original deficit plan of 22.9 million. That plan's now been revised to 15.8 million. We're forecasting a potential adverse variance of that at 9.4 million, subject to the board ongoing discussions, actions described, and the impact of those actions. That will have an impact on what our position is in terms of that, how much we can mitigate that 9.4 million. Any variance against our deficit plan would require further strategic cash cover, and that will be subject to those ongoing dialogue and conversation with Welsh Government.
Are you satisfied, Steve? Anything else?
No, that's fine. Thank you.
Okay. Thank you. So we go now to independent member colleague Dr. Robert Lewis. Over to you, Robert.
Thank you. The shorter waiting times of NHS England, Shrewsbury, Hereford, Shropshire have been a consistent feature for many years, and we've seen that coming through D&P. Of course, better performance is a good thing, and it's something we would like all our providers to emulate. At the same time, our organisation is under great financial pressure overall, and my position is that we cannot preside over a health board which does not have enough money to pay salaries and to deliver the rest of our many services, including primary care. And there is that big risk there in the background. We cannot go beyond the deficit financial limit set by government. Whatever those limits might be, the lights must stay on. And that's the dreadful position we're in. And it's against that background that the board, including independent members, are being asked to explore options for implementation within the financial year, which will have serious consequences for individuals and which may lead to very difficult and sad decisions. But one further observation. Pete has presented us today with a comprehensive indication of the drivers of these extra costs, and of course there will be more financial pressures next year. But I'd like to highlight the costs of delayed transfers of care. By the end of this financial year, this is likely to cost more to the health board than the savings being discussed today. If there was only one thing we could do, one thing we could magically wish away, it would be the unnecessary and crippling costs of patients being stuck in hospitals because care packages are not available. This is damaging to patients' health, clogs up emergency care, and due to its scale, is damaging, hugely damaging to our finances. And while there's little we can do about this today, and much of it is beyond the control of the health board, it's becoming increasingly difficult for me to imagine an operationally and financially sustainable health service in the future while this remains the case? Thank you, Chair.
Thank you, Robert. Hayley, would you or any of your exec colleagues like to respond to Robert's observations?
Yeah, note, Robert, your key description of the pressures that the whole system is currently facing and the impact of that. It was very well put. There is work being undertaken to further improve that, but clearly the scale at which we need to find improvement is substantial. So I just wondered, Elaine, whether you wanted to give a little bit of an overview of the work that we're doing in partnership to try and further improve the situation, notwithstanding that there is substantial a mountain for us to climb to actually reduce those levels of delay, which is attached also to the requirements that were set to us in a 50-day challenge from Welsh Government to focus on and reduce pathways of care delays. I also remind the board of some of the decisions that we took earlier in the year around temporary changes was to absolutely try and address and further improve our performance against some of the matters that Robert has just raised. But Elaine, would you like to give a bit of an overview of some of the key actions that we're taking now?
Yes, thank you for the points and the questions, Robert. I think well made, and it's a challenge that we face on a daily basis. We're fortunate as well to have Nina Davies here, the Director of Social Services. So Nina may want to say something after this and around the collaborative working that we're doing. The key elements for me are very much around the changes that we've already made in terms of our community hospital beds. And over this first month, we've seen about a 20% greater level of admissions from our external district general hospitals into the Powys community hospitals than the same time last year, which is really good progress. And we have also seen through the local authority an increase in the level of domiciliary care available to our population. And I believe it's about 2,000 hours more per week than we had again at this time last year. That being said, there's still a significant challenge. We have pieces of work that we will look to bring back through our executive committee around our reablement service and how we want to progress with that. And we are also particularly interested in looking at what we can do around our virtual wards and keeping people, particularly our frail older people, out of hospital, because we know the harm that can come to them and the delays that they can experience. And if we're able to keep them at home, that's a far preferable position. So there's a number of pieces of work going on and that need to continue, but we're already starting to see some early good signs of progress. That being said, we also acknowledge that there's still much more work to do on that.
Thank you, Elaine. Jennifer Owen Adams, independent member. Please come in, Jen.
Diolch yn fawr a diolch I pawb. Yes, Jennifer Owen Adams, independent member. Robert, diolch am y cwestiwn. Your observation, Robert, I thought that was really well made and actually was something that I was going to ask, but I will ask my other two questions if I may. First one is about the quality impact assessment. I know this is in draft format at the moment, and executive colleagues have been at great pains to emphasise there is more work to be done to that particular draft, which we would welcome. I'd appreciate a little bit more information on what that work is. What more needs to be done to that document, to that draft document, to convert it into a final document, to allow us as a board to have all the data available to us necessary for us to be able to make decisions on this, in this very difficult matter. I know that clearly you've already said that one would need to go and speak to our NHS England partners to get more detail, etc. So I'd appreciate a little bit more detail about what those conversations are going to be like, and is there more work that we need to do beyond speaking with our NHS England partners in order to convert that in order for that quality impact assessment to do what we need it to do in order to aid our decision making. And then that's my second question, is about the escalation. Hayley, you mentioned it, I think, in your sections. Obviously, yeah, we're in level 4 for to targeted intervention for financial strategy and planning only. Can't quite remember when that was. I'm trying to understand, and if you could remind me, please, was that move, or was that increased escalation as a result of the position that we currently find ourselves in? Or do you think that there is a risk that, given our current position, that that targeted intervention could be extended to other domains beyond financial strategy and planning, or even we could be at risk of being escalated to special measures? I'd appreciate your comments on that. Thank you.
Thank you. I'll come in first, if that's okay. And I'll also ask perhaps Claire or other clinical directors may want to come in around the process around the quality impact. But on the point around escalation, our escalation was increased in November. And clearly available at that time was that our progress against our plan financially at that point in time. I would say that the balance of the decisions that we take is about how the finance planning and strategy domain, how do we stay in that same level of escalation, will be dependent on some of the broader decisions that we take in not impacting on the other domains in the escalation framework. So it's really important to look at it in the round, because that's what Welsh Government with colleagues and regulators will be doing, is looking at our overall performance as a health board when they have those assessment meetings regularly. What I would say is that clearly they want to see improvement from us, and there is a concern, and it's a concern I have, that we don't want to increase the escalation in other domains, because at that point that does increase the probability of potentially further escalation against the framework. But I couldn't second guess that, Jen. That is a separate independent process, but it is important that we look at that domain of finance strategy and planning in the round, which is what is the impact across all domains. And clearly Welsh Government with colleagues and advice through the regulatory escalation participants that are involved will be looking at that across the board. So I think that it will be very important for us as a board to be able to give assurance to Welsh Government through this process that we understand the gravity of the position financially, and that we're taking appropriate actions to deliver our board approved plan. And also the other test will be how we set our plan for next year against the conditions and requirements from Welsh Government. With regard to the quality point, I will ask Claire to come in, but I think it's important from my point of view that the broader impact point, Jen, will also be explored alongside scaling exactly what is deliverable in relation to the reprofiling of elective activity in partnership with our strategic partners. But I'll ask Claire to come in just to explain a little bit more around the process of how we actually assess quality in this context. Thanks.
Yeah, thank you, Hayley. Thank you for your question, Jen. So while, of course, in the presentation, we have referred to and described the impact assessment as a draft assessment, that is true. It is an initial impact assessment based on looking at, the wide spectrum of all of the patients that might be on a variety of different waiting lists. And therefore, we have had to take a sort of much more general view in terms of what those impacts would be. I do want to assure board, though, that while it is a draft impact assessment, it nevertheless has been a very significant piece of work that has involved myself and, Director of People and Culture and the other clinical directors. So I don't want to give the impression that it's, you know, in being a draft assessment, it has not had the real focus and the real level of detail and assessment that has gone into it. But what would be required in the aftermath of further discussions with our providers is to understand in further drilling down what that cohort of patients would be. And in doing that, that would enable us to strengthen that impact assessment further. So I hope that sort of answers your question, Jen.
Yes, it does, Claire. Thank you. A supplementary, if I may, Carl, very quickly, which is, and how long is that going to take? We all appreciate that there is some urgency around the situation that we find ourselves in. So how quickly do you think that action can be taken, Claire, in order then for you to come back to us broadly? It might be difficult to be specific, so happy to.
To be honest, Jen, I can answer that. So I think that could be done quite quickly. Obviously, the bulk of the work is done in the impact assessment. It is being able to come back to that assessment with the further intelligence and information we would then know to be able to take a lens on the impact assessment that is far more targeted. But in doing that, in recent weeks, we have prioritised it. We have stood down other things within our collective diaries to be able to have the focus on that impact assessment, and we would continue to do that. So we would respond in a very timely way.
Thank you, Jen. Colleagues, I'm conscious we had the technical difficulties when we started, and clearly because we started late, then our meeting will finish later than scheduled. My estimate is that we will be finished certainly by 1 o'clock. But because we've been going for quite a while now, including the technical stuff, I am going to suggest we've got other people that want to come in on the discussion, but let's just take a quick comfort break and come back in 5 minutes. So that will be 12 minutes past 12. Just a very quick 5-minute comfort break. Thank you. Colleagues, welcome back to the meeting, and we will resume our very important discussion, and I'm assuming that everyone has been able to return to the meeting on time. So we're going to go now to, again, independent member colleague Simon Wright. Please come in, Simon.
Borodar, thank you, Chair. A couple of questions from me. The first is one that takes into account that what we're looking at in terms of the key drivers of the budget challenge we have relates to the above activity than was planned. And I know from my own involvement in the planning process that we can be very confident in the robustness of the plan, but I just think it'd be helpful if exec colleagues could assure the wider public of the integrity of our planning process, and this isn't a consequence of a planning issue. The second area was, I think, put bluntly, so what would the alternatives look like? This is not a palatable decision, but what might the alternatives be, just so we're clear about those. And finally, I wanted to understand how far and to what extent have Welsh Government been appraised and are aware of the context we find ourselves in, and the consequences of what we are considering. I note, and we have noted, and we are grateful for the additional funding. And specific question here is, has that additional funding been premised on the position as planned, or has that additional funding been matched against what we are facing in reality at the moment? How far is it meeting some of those additional cost pressures? Final point then is some concern that we've got quite low delivery confidence currently in what is proposed, noting we have a draft impact assessment, noting the discussion we've just had around that further work to increase our confidence in that. So I just wanted to ask whether and what may need to happen for us to get to a sort of stronger position of confidence in the delivery. I'm assuming through further discussions with our colleagues over the border. So I hope those are helpful. Thank you.
Thank you, Simon. Again, over to you, Hayley, or you'll bring in your colleagues.
Yeah, thank you. I'll start, Simon, with some of those questions, and then perhaps I'll bring Pete in as well on a couple of the points. So the first thing is about the strength of our planning, which is a really important point, the first point. So we set our plan and then revised our plan to a £2 million improvement back in May of this year, and that had additional actions included in order to deliver against that. Every year, when we look at the setting of our annual plan, we start by first looking at the NHS Wales planning framework and the ministerial requirements that are set within that, and assess what that would take to deliver against the priorities set within the planning framework, and then mapping that to the resource allocated to us as a health board. So the approach that we've taken, there are a set of planning assumptions at the beginning of every year, and that approach has worked quite well for us as an organisation. We've used the same approach for a number of years, where we've looked at the level of baseline activity, we've made assumptions on growth, and then we've set the baseline plan on that basis, with very mindful that we also need to set performance trajectories to meet the broader requirements set within our NHS Wales planning framework. I think it would be fair to say that there's always some tension when you're setting a plan around what you know you can deliver, and then being ambitious and pushing the boundaries of what is possible. And I think that's what you saw in the iteration changes between the March plan that we considered as a board, and then the further improvement of 2 million that came back to the meeting in May. But clearly we have had pressures that have been higher than the planning assumptions that we made at the beginning of the year, both in terms of activity levels of emergency and elective recovery. And I think that, you know, the productivity and efficiency elements, particularly in NHS England, has had a much more marked impact than we had anticipated at the beginning of the year. So there is learning there for us in terms of the assumptions that we would make for next year. And I think the other issue, of course, which we've talked at length about, is that the further impact financially on us as a health board for our patients who really do not want to be delayed in acute settings as part of their pathway, or indeed in our community hospitals. The cost per day of those lengths of stay, those additional lengths of stay, has been a substantial driver of the increased cost pressure for us as a health board. So again, in terms of the scenario planning going into next year, we've got to revise our approach to that. And it would be fair to say that also in terms of the differences we've talked about between the expectations around delivery of performance between NHS Wales and NHS England, we will be working very closely with Welsh Government in discussion with them about how we will set an affordable plan within our existing resources going into next financial year. And we have been, I have been we report monthly all of our positions to Welsh Government routinely, but in addition to that, just wanted to give some assurance to the board that I've written separately, setting out both our financial position and also the discussion, appraising Welsh Government of the discussion and the very unpalatable options that we're having to discuss today, and we'll be closely in dialogue with Welsh Government after the meeting as well. Perhaps in terms of the point around what's the alternative and are we, in essence, have we explored every other option? Just wondered, Pete, whether you wanted to just give your view on that, because our view as an executive team is we're bringing these proposals to you because these are the ones that are most likely to deliver the level of financial improvement that we need, and there's substantial actions we've already put in place in order to deliver the initial savings target that we have had to deliver against as an organisation. But Pete, would you like to come in on this?
Yeah, I think thank you, Hayley. I think you've pretty much summarised that. So across the board, we've been focused on all those areas where we can influence our spend, using various analysis, including benchmarking and other opportunities to take action around that. We link in with all the national programmes. There's the Value and Sustainability National Board, which has target action areas that are included within our own savings plans, and we have our savings plan targets we mentioned. So we'll find ourselves in this situation when we got this adverse variance, and these have been identified as those further potential options to mitigate that variance and to deliver our plan. So in summary, yes, all areas are explored, all areas of influenceable spend have been analysed, and where possible restricted, and this is the position we're in where we need to consider these areas. The other point, Simon, I think just to check, so your question around the additional funding. So yes, and we tried to explain this in already in the meeting, but we had a deficit plan, we had a variance against that plan. We've received additional funding, which is well received. It does help to reduce our deficit position, and it does help us going forward. But because our plan target is reduced by the same amount, we still have this adverse variance pressure. So it's still a need for further action to make sure that we remain within that deficit plan target.
You content, Simon? Thank you. Kirsty, please, the Vice Chair of our Health Board.
Diolch, Carl, and prynawn dda pawb. Good afternoon, everybody. Firstly, can I say I was very reassured to hear from Deb about some of the actions that are being taken that will hopefully alleviate some of the pressures on the budgets regarding locum and agency for mental health. We know that demand on our mental health services is significant during this year, and the patients that we are caring for are much sicker than we would usually have anticipated in the services that we have have delivered in the past. So it's really good to see that there is action that will hopefully alleviate some of these pressures going forward. And I'm also grateful to Kate and to Claire, our professional leads, around what steps have been taken to safeguard quality in our own services, in the deployment of agency staff, and in should we take decisions today around vacancy freeze and use of agency, because it's really important that we don't lose our eye on quality. And Hayley, it's been good to remind ourselves, hasn't it, that in terms of the quality of our services, we're not an escalation for that, and we don't want to compromise that in any decisions that we take today. So very grateful to professional leads for their reassurance around there. I do wonder, however, Chair, given what has been said about delivery confidence and the work that further work that could be done to be able to give the board greater information around delivery confidence, and Claire Roach's comments about how it may only be a couple of weeks before the team would be able to give us even greater granularity with regards to the impact any decision on our discussions with English providers around care, that might perhaps give us better information on which to plan a way forward. Obviously, time is of the essence, but Claire's been very clear that that work can be delivered at pace. And I know Nicola is in in-depth conversations with our providers across the border to see what opportunities arise there. Are we confident that all of our providers across the border are following GIRF recommendations? We know that one of our areas of overperformance is outpatient follow-ups, and we know that there's lots being said, isn't there, in research about the necessity of outpatient follow-ups. So I do wonder whether there is an opportunity here to pause, gather that further information, so that we are taking what is a very, very difficult decision. We would be doing that with all the information that is possibly available to us, so that we can be very clear-eyed about the impact that those decisions would have. And I just wonder, Chair, whether there is an opportunity here to slightly amend our approach, and just allow our colleagues to continue the very hard work that they've done to date to get us to this point. And I just wonder whether that would cause our executive colleagues problems if we were to follow that approach today, or whether that is something that our executive colleagues could usefully use to put us all in a position where we can take further decisions, perhaps later at a later point in this month. Thank you.
Thank you, Kirsty. I will invite Claire Roach to come in terms of comment about the quality of staffing and so on. But I share your thoughts and your feelings as I listen to the discussion and follow the conversation today, and indeed based on the information that executive colleagues have shared with us. I think it will probably be helpful to consider what additional information we need in order to consider these matters in the round and in a fully informed way. So my suggestion would be we've got another couple of colleagues that want to contribute to the discussion. Let's continue with the discussion. Let's have the discussion. But based on Kirsty's suggestion, I'll come back at the end of the discussion and suggest a way forward, which is going to probably be around tweaking certainly one of the recommendations that we're asked to consider today. So thank you, Kirsty, very helpful. Claire, please.
Yeah, thank you, Chair. So thank you, Kirsty, for your comments around quality of staffing. And I just want to assure the board that while, of course, it is extremely important that we are looking at and seeking to ensure that we have got constant focus on our spend on agency, we know that that is also not just a financial impact on us as an organisation, but we also know there is very clear evidence to say that substantive staffing in ward areas ensures patient safety much more effectively. We know that there is a direct correlation between the use of agency and safe environments of care. However, I do want to assure everybody that the focus on safe and appropriate use of agency staffing is not at the expense of our safe nurse staffing within our health board areas. We take our responsibility to ensure that we comply with the Nurse Staffing Act very seriously. I regularly review the ward establishments in this organisation, and we monitor our safe staffing on a daily basis. And I think that's extremely important to say. We will always focus on ensuring that our inpatient ward areas have the appropriate level of safe staffing, that our nurses are supported to be able to have professional judgment when they are looking at their areas of responsibility and assessing the level of nursing care required. And it is absolutely about balancing the two. So I just want to give the board assurance that that is in no way being compromised. And at the board meeting later this month, I will be bringing our annual nurse staffing paper, recognising it's been delayed a little this year, but I will be bringing that at the next board meeting. Thank you.
Thank you very much, Claire. Kirsty, are you content, or anything you want to come back on?
I'm very grateful for Claire's assurance on that matter, but thank you very much.
Thank you. So I'm going to go next to Chris Walsh and invite Chris to contribute, and then to Kathy. So Chris, please.
Thank you, Chair. I just want to say thank you to Hayley and the team, first of all, in one of the papers and the presentation that's been given today, and welcome the openness and transparency that you brought to this debate, because I think it's really helpful. I just wanted to pick up in relation to something that Nicola said regarding some of the growth that had come about in relation to activity. And I wanted to ask the question then, is that growth due to our demographic and our age profile? Because we do have an older population, and as you would get older, demand then increases. And are we an exception to other health boards within Wales as a part of that? And has that been effectively considered? Claire's impact assessment, I thought, was really helpful. The focus on the steep of the safety, the timeless and patient-centered issues was really helpful, and brings in that there will be some consequentials to whatever decision we make as a part of it, but these are the really important. And what you've just said, Claire, in relation to Kirsty's questions, I think was really helpful and gave me assurance that things are going to be looked at in a safe and effective and quality matter. The thing for me is that this situation isn't going to go away. So we're going to have to address it at some point. So looking at these areas, I think, whilst it's not palatable in some regard, is essential. I just wanted to ask a question then, is that in relation to the low delivery aspect in some of the discussions with our English colleagues, is that due to the timeline of this financial year being short on over the next 3 months? Or is that because we've not had that conversation with them as yet? To just understand that a little bit more. And then the other one is that if we do make some of those changes where patients are given a longer time to wait in line with the Welsh targets, that could then impact on additional prescribing, additional supportive treatment. And have we factored that into the risk assessments in relation to, will that skew any of those data where we get increased prescribing, which would change away some of the savings that we've already seen in those areas around prescribing and primary care? I'll stop there.
Thank you, Chris. Are you okay if I come in and would ask Nick to come in to talk a little bit about the differences around what's driving the growth? And then I think it's really important to hear from our Director of Public Health around your points around the impact on the demography and some of the other issues that you raised. On the point around the broader impact of this decision, clearly the two scenarios we have modelled so far is a maximum additional wait of 11 weeks. And we will, as part of the more detailed assessment, be picking up the broader impact on primary care, prescribing, etc. It's very hard to be able to complete that at this point until we understand the scale of the level of opportunity being undertaken. But I would anticipate that that would be one of the points that we will strengthen and be able to include in the finalised integrated impact assessment. So if I ask Nick to come in first and then Mez, thank you.
Yeah, thank you, Chris. Those demographic drivers are really stark for us. So we know there's a lot of research, which Mez will probably explain better than me, around the rate of ageing in the population and that demographic shift to an older population driving demand for health and for social care, as you'll be well aware in the council as well. So Mez will explain that, and as we know, we have our proportion of older people is greater than other health boards in Wales and is set to continue along that trend as well. So we are more exposed than other health boards to those drivers of demand. Much of our plan is based on our transformational work to provide more care closer to home and within Powys, but also to use a sort of evidence-based practice to manage some of those demands. And that's an ongoing continuous piece of work that's been in place since the health and care strategy was agreed. And we continue with that alongside our sort of technical commissioning work as well. I think one of the other big drivers that we're seeing is that differential in the rate of recovery, though, post-COVID in elective care. So for many complex reasons, that rate of recovery is accelerating in England compared to Wales. Wales is recovering, but for very complex reasons, partly to do with how services are structured and the demography of our population, that is taking longer. So for us as a commissioner, that is one of the drivers of the growth as well as the demography.
Thank you. Chris, are you content? You're on mute, Chris.
Yes, I'm content with that answer, Chair. Thank you.
Thank you. And so it seems finally, in terms of contributions to the discussions, but certainly not least, we go to independent member Cathy. Cathy, please come in.
Yeah, thank you, Carl. I just want it noted that while we're considering all the proposals today, that we make sure we don't overload the existing staff we have, that we consider their workloads, which all three proposals today could have an impact on staff workloads. We don't want it to impact on quality, retention, and even recruitment. So I'd like it to be considered that we make sure that we do think about workloads for existing staff at all levels and across all services.
Thank you, Kathy. Hayley, is that you or Deb or?
Yeah, I think Deb might want to come in on that because it's a major consideration, Kathy, and what we've been looking at in terms of the preparation around the impact of, for example, the vacancy freeze, etc. So I'll bring Deb in. Thanks.
Apologies, I actually lost connection for part of that. Was your point, Kathy, about the overload on staff of those 3 proposals? Yeah, that's fine. That's fine. You make a really valid point. You and I have had an earlier conversation on this. I think it's really important that, you know, us with staff side, but again, all executive directors in conversation with their senior management teams are keeping a kind of because it won't be satisfactory, will it, if we've got individuals doing a range of jobs over and above the job that they were originally employed to do. So that might mean that we have to slow down some work, or it might mean that we have to change the priorities in which people undertake tasks. I think there's a regular check-in that we need to have between us, and we'll keep all of our kind of feedback loops, whether that be the road shows or chat to change, open, so that we're getting that regular feedback from staff if there's an area that we've missed. And, you know, whilst we've put the vacancy freeze and agency reduction in place, and that will kind of, as I said, be communicated next week, we'll continue to review that. And it doesn't mean to say all recruitment will stop, and it doesn't mean to say all agency will cease. It will be, have we got an alternative? Is there something that we could do instead of spending that money unnecessarily this year? But you make a really valid point, and I'm grateful to you for raising it. Thank you.
Thank you very much. Kathy, anything else? Anything what you want to come back on?
No, that was fine. Thank you, Carl.
Okay, thank you. Well, thank you all very much for the way in which that discussion has been held, both the information, the comments, the suggestions, the questions, the answers, and so on. I think we've had a very full, frank, and comprehensive consideration of these important matters. I want to go back to Kirsty's suggestion earlier that we might, on the back of this discussion, just have a little bit of a think about how we take things forward. And so I've been just playing with some words, as it were, in the background, and in our chat facility, if this works, I'm going to suggest an alternative recommendation. So we have the recommendations as they are printed in our papers, and I think all of them but one stand and need no further amendments. However, it seems that in our discussion, what we have recognised, and certainly what Hayley, Pete and the exec team have also brought to our attention, is that further work does need to be carried out with particularly our NHS England providers to be very clear about what the art of the doable is, what the art of the deliverable is. And we don't really know that yet until we have those conversations and negotiations. Also, as a number of people have highlighted, and again, as the executive have brought to our attention, the impact assessment is currently in draft form and therefore also needs more work, and crucially important, we need to understand very, very clearly the impact of our decisions on people, on patients, on communities, on GPs and other partners and stakeholders. And we don't quite yet have that full information in place. And therefore, we are not in a position today to make a fully informed decision as regards the penultimate recommendation as it stands. And therefore, you'll see that I'm suggesting that we substitute the current penultimate recommendation with my suggested alternative, which is that we discuss and support the assessment of the opportunity with NHS England providers to revise elective activity during Q4 in 2024-25, and to finalise, on the back of that, the integrated impact assessment to inform the board's final decision. And of course, we will need to reconvene as a board as quickly as possible in order to do that. Sorry, thank you, Helen. I realised that I hadn't pressed the send button that included it in the chat pane. So thank you very much for doing that. And there it is twice now. So that's my suggested submission, or my suggested alternative to the current penultimate recommendation. So before we come to the recommendations, does anybody want to indicate that they don't agree with the substitution of that recommendation? I can't see anyone indicating, and so I'm going to therefore conclude that there is unanimous support for substituting the current penultimate recommendation with my suggested alternative. And again, I'll just pause briefly should anyone want to come in and say otherwise. Okay. Right. So that's that is therefore the alternative that is in our recommendations. So I come then to the recommendations, and I'm not going to read them out verbatim because they are there in our papers for us and indeed the public to read through. But I will just go through them very quickly to remind us, generally speaking, of their content. A number of the recommendations ask us to note where we are and the current situation. So we are asked to note the financial position at month 8. We're asked to note that Welsh Government has been very clear in its expectations of us in relation to the requirements placed upon us and delivering against our own submitted 24-25 plan. We're also asked to note the actions already underway and the additional urgent actions that have been agreed for Q4. Also, we are asked to note the current assessed gap in the 24-25 plan of 9.4 million, therefore needing actions, additional mitigating actions. We are, in addition, asked to note a potential total of £10 million worth of mitigating actions that we have been taken through today in our papers, in our presentation, and during the discussion. We're asked to note that no further contingency is available to support investments, mitigate any unforeseen pressures in Q4, or any changes in funding planning assumptions. We're asked to note and support the immediate delivery of variable pay reductions through reduced use of agency and locums. Now, just an explanation that this work is in the operational space, as it were, and it is already being taken forward by our chief executive team, and managers across the organisation. So, therefore, we're not asked to necessarily approve that, but to support the continuation of that action. Equally, we are asked to note and support a vacancy freeze for all posts to be overseen by the revised vacancy control process. And then, importantly, instead of the recommendation as it reads on the paper, we are substituting that with discuss and support the assessment of the opportunity with NHSE providers to revise elective activity during Q4 in 24-25 and to finalise the integrated impact assessment to inform the board's final decision, recognising that we will need to reconvene very soon in order to consider that additional information. We're also asked to note that ongoing dialogue will take place with Welsh Government, which will advising of the board's decision and requesting ongoing discussions regarding next steps and so on. And discuss and support the assessment of the opportunity. Sorry, I'm repeating myself now. So, so discuss and support the assessment of the opportunity to revise the the papers in front of me are a little bit confused. The final recommendation is the one that says note that we have an ongoing dialogue with Welsh Government. I apologise for causing a bit of confusion at the end there. That is a composite recommendation with those different elements in it. So I'm going to put it to us as a composite recommendation, and I will ask, therefore, as we often do in these online meetings, does anyone want to indicate that they don't support the composite recommendation? No one has indicated, and therefore that composite recommendation is unanimously supported, amended as it is by the alternative recommendation. Thank you very, very much to each and every one of you for the meeting today. Very, very difficult matters, very complex matters, and I'm grateful for everyone's contribution, executives and independent members alike. So just before we finish, I am going to offer a final opportunity for just some closing comments. I'm going to go initially to our Chief Executive, to Hayley, and I also understand that Katie from Llais in Powys also would like to make an observation. So first to you, Hayley.
Thank you very much. Can I firstly thank the board for the level of discussion and scrutiny and questions that we've received regarding both the position of us as an organisation in relation to delivering our plan, but also the discussion and revision of that recommendation has been a really important development through the discussion today. So huge thanks. And clearly our role as an executive team now will to be moving forward at pace to further explore and take action and to be ready to bring back to the board the additional work on the integrated impact assessment and delivery confidence for your final consideration. So wanted to give assurance to the board that we will continue the work at pace immediately after the meeting with regard to that. I think the final point from me is, and I'm not sure what Katie wants to cover, but the communication of this discussion, but also the level of interest and concern from our communities and patients around the discussions that we've had today, that we will be putting particular attention around how we communicate, also especially with our staff and partners around the discussion that we've had in the board today, and how we will be communicating throughout the next few weeks around the progress that we're making around the position. So I just wanted to just reinforce the point that Llais raised about the importance of reassurance and communication to patients and the wider population, and that is part of the implementation planning we'll take forward as an executive team. So thank you. That's all I wanted to say. Thanks.
Thank you, Hayley. Katie, please come in.
Thank you, Chair. Just to say, Hayley's covered it. So thank you, Hayley. Just to make sure that as part of this process, it's about continuous engagement with the communities and individuals of Powys, and I think that's really important. I appreciate the timescales for this paper, and I appreciate that it was in a very sort of business board format, but I think it's really important that going forward, the communities and individuals are kept in touch with future developments. Thank you.
Absolutely, Katie. Really important matter, and as Hayley says, we will certainly be doing that and doing that very comprehensively. So, just i gloi, diolch i galon i chi gyd am eich cyfraniadau gwahanol, un trafodaeth heddiw, fel dyn ni wedi cydnabod, dyn ni wedi trafod materion anodd a chymleth, ond dyn ni yn ddiolchgar iawn am bob cyfraniad heddiw. So just to close, a big thank you once again to everyone who has prepared for this meeting, enabled it to happen. Apologies once again for the technical difficulties we had at the beginning, and I'm glad that we were able to resolve those. And that concludes our business for today, and therefore I close this meeting. Thank you.